There's been a lot of medical interest over the past few years in psychedelics, specifically psilocybin, in the treatment of depression. And the interest has really picked up steam over the last few months. Oregon already made it legal to dispense psilocybin in like an approved setting, and there have been major studies along the way kind of pointing to its benefit. But really this major piece of data came a few weeks ago when psilocybin went head-to-head against Lexapro, escitalopram. All right, one of the major SSRI antidepressants, selective serotonin reuptake inhibitors. And keep in mind, there really haven't been any kind of major changes to antidepressant pharmaceutical therapy since those drugs really came to market and started to get widely prescribed in the 80s. So we've made some slight adjustments here and there with with Effexor and Cymbalta and stuff like that, where we're playing around with which neurotransmitter chemical messenger we're targeting the most. But the theory pretty much stayed the same. The theory is that depression is caused by a chemical imbalance. All right, so we can correct it and treat it by pharmaceutically keeping more of those compounds in the synaptic space for longer. That's the basic idea. Whether it's serotonin or norepinephrine or dopamine or whatever, it doesn't matter. If you're lacking it, we got a pill for it, except oxytocin. Actually, oxytocin has actually been indicated in a lot of depressions, and that we don't have a good pill for that. We don't have an oxytocin reuptake inhibitor. You could always dance and sing and play music or hug somebody, but you can't really package up hugs nicely into a pill form. So we don't really talk about oxytocin quite as much. We like the theories that include chemicals that we already have pills for. So anyway, that's a topic for another time. But so then what is all this? What is this psilocybin noise that everybody's been talking about? And kind of how is our traditional abstinence-based model of recovery gonna survive this? Gonna survive psilocybin because it's coming, baby. It's coming, and there's no stopping the train. But I mean, look, as if the abstinence-only treatment model is even something that should be desperately protected. I don't know. I mean, it works. I don't know, for 5% of the people, if I'm being generous. Now, I happen to be part of that 5%. I work with a lot of folks that are part of that 5%, and we tend to be a very vocal minority, but we can't pretend that that this is a model that should be forced on everybody. God only knows that we've had enough time to try to do that. But as far as this video and the topic of this video, on April 15th of this year, the New England Journal of Medicine released this bombshell of an article where psilocybin competed against Lexapro. It was a 2-arm, double-blinded, randomized controlled study. There were 59 people. They got broken up into 2 groups. Everybody was diagnosed with major depressive disorder. So it was a small study. Like the first head-to-head ones usually are, but it was well controlled, and there were a few take-home messages that I'll try to highlight here and then kind of give my thoughts. So and this isn't the first time that we're seeing psilocybin show positive results in controlled studies. Not even close. There's a researcher in Johns Hopkins. I'm actually drawing a blank on his name, but he's been researching and publishing his findings for decades. He's talked about psilocybin with reducing the pain associated with cancers, psilocybin for quitting smoking, other chemical dependencies, and it's been hard to study though. That's the problem, because it's a Schedule I controlled substance, which means no legal accepted medical uses. A lot of this research started coming out in the 50s. There was a ton of research into this stuff, and then with the kind of psychedelic boom of the 60s, a lot of people started using it, a little bit recklessly, maybe in a non-therapeutic setting.
Blood. They wrapped the pineal gland, I think. Yeah. No, how's your mama?
Ignore this terrible drug.
And then once the government, caught wind of that, they did what the government does, and they banned it completely. But they also banned all the research funding. Okay, so we went through these I guess dark ages, if you want to think of it like that, in terms of like psychedelic research. But it's back, and like I said, studies like this where it's being compared head to head with the top dogs, they're making a big splash. I mean, it's like if you have like an up and coming fighter, okay, and he's fighting a bunch of like no name guys, and he's winning. The guys at his local gym might recognize like that talent, but most people aren't really taking notice. Most people aren't talking about him. But if you throw him into the ring with like the champ and he knocks that guy out, okay, now you have everybody's attention. So this study, it wasn't exactly like a knockout, all right, but we can call it. I mean, it was a pretty, it was a convincing, unanimous decision for psilocybin, and but I'm sure that the promoters are actively scheduling a grudge match. Remember that a lot of companies have a lot of money, kind of like invested in the interest of these SSRIs, and they're not going to just hang their heads and accept defeat. You can be sure that they're going to fight this one to the death. Well, at least until they can find a way to make money from psilocybin, then they might back off. So anyway, there were basically two significant differences between these products, psilocybin and escitalopram. The first is the speed, okay, the speed with which it had an effect. The SSRIs are notoriously, they take about 4 to 8 weeks to really start working, okay? And actually, one of the most dangerous parts of SSRI treatment comes in those first few weeks. That's why we have a black box warning. And a good practitioner is really going to follow up very, very closely during this time, because what happens is that the patient's motivation and energy, starts to come back, after maybe like a week, a few days to a week on average. But the actual mood doesn't start to improve for about 4 to 6 weeks on average. And if you're using it to treat, generalized anxiety, it might be 6 to 8 weeks for full effect. So if you take somebody who has a suicidal depression and then you inject them, so to speak, with energy and motivation to actually do something while the mood stays depressed, well, the risk to actually go through with a suicide attempt goes way up. Okay, that's why, especially with young adults and adolescents, they really need to be closely monitored during that time. It's the most dangerous kind of part of treatment is when it's first being introduced. There have been many successful suicides, also homicides, from people taking the SSRIs. Like I said, mostly younger people, particularly in the early phases of treatment. And this is well known. This is, so most people actually do monitor pretty closely. But what we saw in the study with the psilocybin is that it worked a lot quicker than the Lexapro, okay, which would lead me to think that that the increased risk of suicidality during those first few weeks, that it likely wouldn't be as pronounced here. Okay, now that's just a guess. We don't have there's no data to kind of support that. I'm just making the hypothesis here. We usually don't figure out stuff like that until the drugs are being used in a non-controlled setting for a while. But if the mood does improve quickly, it would be expected that the risk of early treatment suicide, like you might see with SSRIs, that it goes down. So anyway, okay, so what happened here is that after about 2 months, that's how long they followed these two products, the efficacy of those two classes when it came to direct symptoms, okay, which is to say sadness, and the inability to feel pleasure, those kind of the traditionally monitored depressive symptoms, we found that it was about equal. Okay, they both improve those direct symptoms, about the same way. But there's also a lot of ancillary symptoms with depression. Okay, a lot of other stuff. Things like the desire to engage in social activities, quality of sleep, nightmares, general outlook on the future. These are all these more ancillary symptoms of depression. And when it came to those ones, psilocybin did a little bit better. Okay, so to kind of sum up the basic results of this study, they worked equally well to treat the direct symptoms of depression. Lexapro did a little bit worse when it came to treating the ancillary symptoms of depression. The psilocybin worked quickly, and also it didn't come with quite the same magnitude of side effects that have become so well known and characteristic of the SSRIs. In terms of limitations of the study, most of the patients did self-refer. Okay, so that means that you're selecting for people who would have been more enthusiastic about taking psilocybin in the first place. That's why you can imagine that might be why they were signing up for it in the first place. Okay, another thing, it's kind of hard to completely blind against like a psychedelic, because the effects are usually noticeable. Like you would know if you actually took that, but they did. I don't have time to go into exactly how they did it, but they actually did correct for that. They found a way to try to kind of separate that potential confounding factor. All right, part of the mechanism of action of psilocybin is that it does work directly on serotonin receptors, but in a completely different way than the SSRIs. It's a completely different type of treatment than anything that we're using now. And if the set and setting are right, okay, which is to say, it's done in a safe place by a well-trained practitioner, the patient might have the ability to access these parts of the mind, parts of the psyche that may be suppressing or have these like depressed emotions that have been manifesting as depression, manifesting as anxiety, other signs of poor mental health. Now, like one of the problems, of course, all right, is that these psychedelics cause hallucinations. Everybody knows that, auditory, visual, like hallucinations. So the dose has to be right. Okay, that's like the microdose that you'll be hearing about when everybody's talking about psilocybin. We're not handing somebody a bag of magic mushrooms and saying, call me in the morning. All right. And again, everything here when it comes to psychedelics, it's all set and setting. All right. So, you go and buy that bag of shrooms from your dude down the street, and you want to treat your own depression, and you sit in your basement and you eat that whole bag, trying to cure yourself. Yeah, you might be in for a bad experience. So we need to really kind of keep all of this stuff in context. But psilocybin isn't addictive, in the classic sense of like a benzodiazepine, for example. Like you're not taking this to like tranquilize your brain or like shut off your emotions. It's actually the exact opposite of that. The idea is to allow access to those emotions that, like I said, may have been kind of unconsciously suppressed, for a long time. So we're not trying to shut off here. We're trying to turn on, So there's definitely like a lot of interest around this. You're going to be hearing a lot about it. All right, depression is complex. There's no such thing as a magic bullet cure for it. All right, I don't expect that there ever will be. That's not what this is. But studies like this do go a long way of helping people understand the use of psychedelics for the treatment of these different psychiatric disorders, psychiatric conditions. But psilocybin is a psychoactive drug. Okay, so you can be sure that the recovery community is going to be weighing in on it, as we do, right? And we'll also see how this abstinence-based treatment model is really gonna hold up to all this. Ketamine treatment, is already here. MDMA, all right. I've talked about marijuana in a couple past videos, specifically as it relates to the opioid epidemic. And the short answer is that we don't know. In 1960, like Librium was brought to market, and it was touted as the final cure for alcoholism. But alas, it was not. And I put out a video a few months ago about benzodiazepines, the history of benzos, and all these other classes that we brought to market, and just how everybody gets so excited about them, which is not the fault of the masses, by the way. These folks are incredibly talented and skilled at like hyping up their products, and they have honed and kind of tightened that craft for a long time. It's not that you're stupid or gullible for falling for new hype of a new class. I mean, this stuff is done with incredible precision by incredibly talented people, but still, okay. And this is coming from somebody, as skeptical as anybody. Like when it comes to this stuff, I'm optimistic about psilocybin. I really am. There's a reason, for the epidemic of depression over the last 50 years. And it's not that, suddenly everybody just inherited this chemically imbalanced brain. Genes don't change that quickly in a population over such a short period of time. Obviously, something else is going on. Something that needs attention, and that and part of that something, seems to be that we're not able to access the parts of our mind that have been, locked in this like depressive loop. And if there are products that, in the right set and setting, under the right conditions, can possibly tap into that, I say, let's see what they can do.